I think we can start. I think we can start.
All right.
Yeah, good afternoon to everyone in the class. Good morning for some. Can you share the slide?
Okay. Good morning, good day, everyone. Good morning, good day, everyone. Welcome to session 3 of our oxygen therapy and critical care, the case-based series with Dr. Francois Umimina from Rwanda. This is the third session in the series. Just a quick recap of our housekeeping. You can use the chat function for your questions. If you have questions and answer, please kindly use the chat function. If you have IT issues, also please use the chat function. Then the session is being recorded and your attendance is consent to being recorded. Thank you.
So the attendance being also recorded, and during our certificate and the CPD credit preparation, we will take consideration of your attendance. So the attendance is also recorded and considered.
Okay, so Dr. Wimena, if you can, the floor is all yours. You can start and then kindly introduce your co-panelists to us.
Thank you. Thank you. Yeah, today is our third session. The session on escalation to higher level of care. We are having to have effective this class or this e-learning session. We are in partnership with ECHO program, also with the Assistant International. We are having also the University of New Mexico, where we are running our resources in the Running Resource Center. Next, please. Next, please. Next slide, please. Okay. As the basic or the principle of our hub or our e-learning, we are always having case-based discussion. I'm also inviting the audience, if they may have any case to their health facility, they may share it with us while we are preparing the forthcoming sessions so that we take them into consideration. A case we are having today is a sick with 2 days and fever. The patient is screened for COVID-19 risk factors, isolated and wearing masks. Would you admit this patient to the hospital or just manage him at home in what we call home-based care, HBC? What disease severity does he fit in? So this case, as we discussed previously, risk factors for COVID-19, everyone is aware of it. And when you are having such case, which we called now a suspected COVID-19 case, so you have to take measures like isolating and wearing mask. Next, please. Next, please. From the case, we are having learning objectives we want to cover. In such case, we are discussing, we have to know when using triage protocols and the criteria. Also knowing the COVID-19 severity classification plus post-COVID syndrome which actually we may be facing after we close our COVID referral center of Nyarugenge and now using isolation rooms all over the country. How to design isolation area for suspected COVID-19, as I'm saying, in different health facilities, isolation rooms, as we are setting up them to receive those suspected or confirmed COVID cases, which are not in critical condition to come to our hospital. COVID-19 diagnostic tests and the result interpretation, we'll be covering it, and the protocols for escalation of oxygen therapy, which is our big goal because the COVID-19, the first treatment is need oxygen, 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 oxygen. So how to deliver it? We are going to cover it and escalate on it. The other objective is respiratory failure in the adults and the chest X-ray interpretation in the context of COVID-19. Respiratory failure being
Hello. I think the Dr. Xavier is disconnected. But as he was saying, our learning objectives. Can you hear me?
Yes, we can hear you.
Yes, please.
Yes, we are hearing you. Okay. As he was saying, we along this course will be learning respiratory failure in the adult and the chest X-ray interpretation in context of COVID-19. Also, we'll be having when patient need to be evaluated by senior physician, an ICU team. Even if like our district hospital have been setting up some isolation at their area, but we still receive one referral center for patient with the respiratory failure, where the senior physician will be evaluating those patients and decide to send them to the designed area for those critical sick patients. And okay.
Continue.
Also, it will be like first aid patient care that's the critical outside of IC in the context of available resources. As long as those patients, they are outside, they are in the district hospital, but there is a minimal thing they can be done before transfer or along the transfer, so that he may arrive at the treatment center safely. Okay, you can go to the next slide.
So thank you, Dr. Apollinaire. To achieve our learning objectives, today we are having three presenters. We're having Dr. Apollinaire, is an emergency physician and a critical care physician at King Faisal Hospital. We are having also Dr. Venus, is from Kibuye Referral Hospital, COVID-19 wing. Also, we are having Dr. Joseph, is an emergency and critical care physician at University Teaching Hospital of Butare. And around the side, we're having like our backup, Madam Liberata, who is a lecturer at University of Rwanda. So the three panelists today are now going to help us understand and triage and isolation rooms, as Dr. Apollinaire was introducing. Screening and testing help us how results are interpreted, disease severity and admission criteria. At the end, also, Dr. Apollinaire will be talking to us reinfection and post-COVID syndrome for this 1 to 4 message above to cover our objectives. We will be also going through revision of oxygen therapy we had in 2 previous sessions, oxygen devices, flow, and FiO2. How do we escalate? How do we adjust? We will be focusing and emphasize on algorithm for oxygen therapy. We'll emphasize also on critical care outside an ICU, and we'll be taking kind of overview about non-invasive positive pressure ventilation, known as Cpap or BiPAP.
Okay, thank you. Maybe also there is another disconnection with Dr. Xavier, but I may introduce my course. As he said, we'll be talking about triage and hospital admission criteria for those COVID patients. We'll be talking about how we diagnose, and we'll be talking about the severity of COVID-19. Triage of COVID patients, it's like will be assisting us in sorting out our patient from like casualties, because the patient while coming at the hospital is not coming saying that they have COVID. Most of the time they are coming as usual patient, and then on the triage, we are there to know who is with high probability to be COVID-19. After, you determine priority of need in the proper place of treatment of those suspects, till proved either positive or suspect or negative. Those areas where we'll be like putting our patients have to have possibility to allocate those patients and to give them an assistance. There is a standard operation procedure for triage of suspect COVID-19 as the SOP of COVID management in the concern, or have been published by Ministry of Health. We have like the third session where they give us a guideline how to recognize those COVID patients, signs and symptoms, and the way to put those patients if they are like COVID negative or there is identification and the separation of suspect patients at the triage is important to prevent transmission from other patients who are coming for other health facilities or other healthcare providers. We know it's a very contagious disease that may be aggravated by previous history of our patient. For example, if a patient is coming for like refilling his medication, and then he's not the same triage with another patient with COVID, to recognize that one who is with the signs and symptoms of COVID and put aside, do an early diagnosis will help those cross transmission of virus. Those can be done while you have like a good setup of the triage, and that setup of triage have to be in waiting area or before entering at the hospital. Next slide. Okay, as we tried to do a drawing on how the triage have to be set, there is an area where there is someone to do screening and the patient. And then at that triage area, because they have to be like at least 1 meter between one doing triage and the patient. When there is someone who is having respiratory symptoms, it's better to have their way because they are suspect as we are in a period of COVID. But another one who is coming with other signs, for example, is coming for fracture, he's coming for refilling medication, they have their regular waiting area. Meaning that separation of those patients will help us to emphasize on those with respiratory symptoms to screen immediately for COVID. After their screening, the doctor or healthcare will decide. Next slide. At the hospital, it will be better to have like at the entry point, the signs that show patient flow, and then to orient patient with symptoms differently from patient without symptoms. At the patient with symptoms, also they have to be triaged because they are not in the same severity scope. For example, while triaging, you may find one is having respiratory symptoms and with hypoxia, he or she need immediately to be given oxygen. Then those patients also have to be in a distance of 1 meter. If they don't have mask, they have to be given mask. And those masks will protect others who may not having that COVID. For normal patients, it's easy. They'll be looking for their care as usual, but also the treating doctor may also do another screening to know who is at high risk of getting COVID. Next slide, please. After triage, there is, as we said, there is some who are having respiratory symptoms and the others without respiratory symptoms. People who will be having respiratory symptoms, according to our guideline, they are suspect of COVID. Meaning that when they are suspect, they have to be triaged again and then separate them accordingly. They have to be given mask, as I said, and they have to put on. If masks they are not available, they may even cover their mouth with some cloths or tissues. If they are like very sick, they have to be in a single person room with door closed. If there is no one person room available, put in one room with like separate with 1 meter. Again, that room have not to be closed to keep well ventilated area. Only health workers who are also protected will be going inside with PPE to keep their vital sign checked to be given medication. Those cases will be kept in that area while waiting their results, because you cannot discharge them while they are suspect without knowing their status. Next slide. As we are saying, if you have in a room with person we suspect with a COVID-19 suspect, as we have been saying, all patients with confirmed or suspect COVID need to be placed in airborne infection isolated room. But there is something to consider. Those with those respiratory symptoms may not have that COVID, meaning that all, according to your triage, if there is a high risk, someone who is at high risk or who is meeting all criteria of COVID will be separate from others. And there are IPC guidelines that recommend placing patient in irregular examination room with the door closed. Those airborne infection isolated room should be reserved for patients undergoing aerosol generating procedure or for diagnosis such as like active tuberculosis. If a patient is coming and need nebulization, you know that nebulization is an aerosol generating procedure. He will be put in airborne infection isolation room. The patient who will be needing intubation, because you know that the procedure is isolizing, but the patient who are like normal, who are having simple or symptoms of COVID, it's not mandatory to be put in the airborne infection isolation rooms. Patients with known or suspected COVID-19 should be cared for in single rooms, as we said, with a door closed. If there is no single room, they may be in the same room with a separate 1 meter between a bed and the room have to be well ventilated, meaning that you will not close doors, you will not close windows. Next slide. Okay, while screening those patients that you are suspecting for COVID-19, many people may be contagious without experiencing symptoms, meaning that if you have suspected someone, it will be better to be protected while doing screening or testing that one. The targeted testing or screening is an inappropriate strategy to limit the spread of COVID-19 between patient or between patient and the healthcare providers. There are like 2 types of tests can be done. There is a viral test for the current infection or antibody test. If you are testing antibody, you are looking if there is, it may be a present or past infection. For viral test, you will be looking if there is a still viable viral. Next one. And the available diagnostic investigation for COVID, which I think they are available. They are rapid tests PCR or imaging. For rapid tests, it will be completed with the blood count with differentials, because with COVID, in the evolution, there is a change in our blood count. PCR also may be completed with metabolic profile, liver renal function test, and electrolyte. As you saw we will be seeing that PCR is a gold standard, but some studies have shown that the PCR may be negative, but the imaging to be considered if it looks like ERDS. Ultrasound screening may be done and also computer tomography, scan, or electrocardiogram can also complete our SARS-CoV-2. Okay, to detect our COVID-19, as we said, two tests may be showing if you are positive or negative. Rapid tests depend on what kind of the test. Their sensitivity and specificity may differ. PCR is a gold standard. Also, we have to think about also imaging that may show images in favor of COVID-19. Next slide. As I was saying, for PCR, which is reverse transcriptase polymerase chain reaction, will be either negative, presumptive, or negative. If it's positive, there are 4 genes that will be detected. And all those genes, if they are available, the test will be considered as positive. But if any of those 4 genes is absent, the result will be presumptive. According to our guideline, if the result is presumptive, you have to wait 72 hours to repeat the test. At that time, the test may be positive or negative, or still presumptive. The negative test is when none of those genes they are available. For rapid diagnostic tests, they are looking for antibodies or antigens. Is it positive or negative? It's positive if there is availability of antibody or antigen, depends on the test we are using. And when it's negative for rapid test, meaning that there is no antigen or antibodies detectable for the patient you are testing for. Next slide.
I think there is a question. Someone has raised their hand, Sherman.
Okay, she can express herself as a comment or a question. Can you unmute Saf for the question?
Okay, maybe that was their mistake. Shamant, if you'd like to ask your question in the chat, feel free to do so, but we'll keep going.
Okay, I can keep presenting. Maybe she will be writing the question to the chat or ask the question at the end of the presentation. Okay, as we're saying, according to the time or the patient have been with symptoms, there is a production of detectable antibodies, meaning that you may do those rapid tests while antibodies or antigen are not enough to be detected by the test. It's why some tests have you have to be completed with PCR to know if it's a true positive or a false negative. The test, most of the time we are doing a nasopharyngeal swab or deep spectrum, sputum, and then for antibodies or antigen, we may use blood or use also the swab. The window period may be short for PCR, but for antibodies, IgM and IgG, 7 to 10 days after symptoms, and the antigen also they are short. For the false positive, in PCR, almost none is there, but for antibodies, they are low to moderate because you may be having a cross-reactivity to other cross-reactive with other coronavirus different from SARS-CoV-2. And the antigen, they are very low, as long as you are looking for virus. The false negative for PCR, they are occasionally low. And for antibodies, they are variable, especially when they're at high onset of the symptoms. And they are moderate when you are looking for antigens. The turnaround time for laboratory, it depends on the laboratory. For PCR, because some laboratory within 2 or 4 others 6 others 8. It depends on technology are using in their PCR. For antibodies, it's 15 minutes. And you don't need the laboratory because you can even set up on the table. And for antigen, it's the same in 15 minutes. You don't need a laboratory equipment, a high laboratory equipment for testing. Next slide. Okay, as a clinical spectrum of SARS-CoV-2 infection, there is a day of exposure to COVID. Maybe you meet someone with COVID and immediately you don't get symptoms. The symptoms are estimated to come after 5 days post-exposure. Then on day 12, if you are immunocompromised or you may be admitted at hospital, and if you fail, your immunity has been failed, the ERDS, acute respiratory distress syndrome, may occur at 13 days post-exposure, meaning that the severe symptoms occur at least 10 days after exposure. And as you can see, COVID patient may have mild to moderate disease. It depends. And 40% may have mild disease. Other 40% will be having moderate, may come from mild disease to moderate condition. And among those ones, 15% may get a severe disease, and then 5 of them may be having critically sick patient. As you are following the previously when we were in SARG, you were looking, for example, we're having around 2,000 patients, but among them, at least 10 of them, they are like in critical condition. Next slide. Okay, as we saw in the previous slide, the exposure to COVID will lead to the body will try to make antibodies. And then there is at least 3 stages for our patient. When there is infection in stage 1, there will be a viral response, which will lead to presence of symptoms. And then if the patient may continue to be in stage 2, where there will be a preliminary phase, and the progression may arrive at the stage 3, where there will be hyperinflammatory inflammation phase. And most of time, at that time, patients, they are developing ARDS. In the early stage, as we said, stage 1, the clinical symptoms you may see, there will be referred to mild constitution symptoms like having fever, dry cough, headache, diarrhea. And those are like most of common symptoms we are seeing in our OPD patient. And when you look in their lab results, you will be seeing lymphopenia, increased prothrombin time, increased D-dimer if it's your laboratory will be able to do it, and the LDH. By the progression of the disease, you will be having shortness of breath in stage 2, and most of patients will be in a PF ratio less than 300. If you do exams, you will still having abnormal liver enzymes. You will be looking abnormal chest imaging as long as they are be having pulmonary symptoms. For the 3rd stage, the clinical symptoms, they will be having ERDS confirmed. And sometimes they are in shock, and sometimes they have cardiac failure. For clinical signs, they will be having elevated inflammatory markers, CRP, ERDA, interleukin-6, D-dimer, troponin. Those enzymes will be elevated. And as you can see on the slide, there is a potential therapy we can consider at that time. It will depend on the protocol used in the country, but in the phase 1 and phase 2, in our country, we no longer have remdesivir, but you are losing BAM and bamviramine and Cpap. And when they are in stage 3, stage 2 to stage 3, because they are like they have inflammatory response phase, we are giving touching. And in stage 2, the only we are giving also steroid for those patients. And for stage 1, we are using medication to reduce viral replication, especially favipiravir. Can we go to next slide? Okay, as I was saying, the COVID case management in Rwanda, as I have been introducing that when the patient is coming after triaging that he has respiratory symptoms or has signs and symptoms of COVID, the test is done. If it's confirmed and the patient is asymptomatic, they do self-isolation at home or campus or other camps. People with mild infection or mild symptoms, also they are given medication and self-isolated at home. But for patients with moderate, immediately they are admitted at treatment center, especially nowadays they are kept at the district hospital. If they keep deteriorating with severe condition and critical, they are admitted also, they are referred to COVID-19 treatment center established by the Ministry of Health. And those patients, they are referred because some district hospital, they are facing problem with the oxygenation or ventilation or staff who can manage those very critical patient or intubated patient. Next slide. Maybe further on this, we'll be looking at them on escalation of care, but I can't end my presentation without talking about COVID-19 reinfection and the CT values. Reinfection of COVID after recovery from prior infection has been reported as early 3 weeks of initial infection diagnosed. But some studies, they are also saying that after it's between 3 weeks to 18 weeks, because some they are saying antibodies are there until 6 months. The frequency of reinfection may increase the circulation of a new variant. As you know, we are facing with like a possible mutation worldwide. If someone has been infected with beta variant, if he's meeting someone with Delta, he can be also again positive. The detection is the same, and the incubation time will keep the same. And for the patient who have been infected with COVID, if they get like new symptoms, they have to be considered as new infection till proved otherwise. The treatment of those reinfection should not be different from treatment of medication used in initial infection, because we saw that those, as long as you are developing a new variant or you have a new variant, those medication who will stop viral replication will act on the same as previously, and those medication we are using for to reduce inflammatory markers also will act as if it is a new infection. Next slide. Okay, to end my presentation, I would like to talk on post-COVID syndrome. There is a patient who are experiencing persistent symptoms and organ dysfunction after acute COVID-19. Those, they may be long COVID, they may having long haulers or post-acute sequela of COVID, or late sequela of COVID. Those sequela may extend from more than 4 weeks to 12 weeks after initial infection. And if common findings include, there is a fatigue, there is a joint pain, there is a chest pain, there is palpitation, there is short of breath, there is a cognitive impairment and worsened quality of life. Also, we can't forget that some patients who have been COVID positive may experience a late recovery or a late recovery of their respiratory system. Meaning that after COVID, if they have been intubated for a long time, to continue with the weaning from oxygen will take like a long process. This process will include physiotherapy to do chest physio, and to keep to try to wean as soon as possible as a take-home message. As a take-home message from my presentation, it will be good to do a good triage while at the hospital, and then with our triage, we differentiate our patients who are having symptoms with others without the symptoms, and with the patient with symptoms to reduce contagiosity between patient and healthcare. While diagnosed, a good orientation, a good early treatment, or a good early intervention will help our patient to recover quickly. And patients who are having post-COVID symptoms have to be considered and get a good medication and a good support, especially they need psychological support as long as they have been having a severe disease. Thank you. I think we will have a bunch of questions at the end of presentation.
Yeah, thank you, Dr. Porner. Thank you for your conclusion, take-home message. We are running over time, but we can take some 2 to 3 questions from the audience. And as you still here, you can give some answers from what they will be asking. To the audience, the floor is up to you for 2 minutes, and we go to other presenter.
I think if there are no more questions, no questions at all, we can go to the next presentation, and we shall have questions after the 2 presentations.
Yeah, thank you. Thank you, Venice. The floor is up to you. The patient has been triaged, as Dr. Poner said, has been isolated, and also has been transferred to this airborne infection isolation room. But there, the nurse took vitals and found the spot is 8 on Numea, and put the patient on 5 liters per nasal cannula. By blood pressure 110/56 of and the respiratory rate 32 cycle per minute. And from the presentation of the Dr. Porner, which classification the patient may be in, and then from that question you classify a patient into the 5 categories he described above. When then should your oxygen therapy be escalated? And what is the role of a wake-prone position in oxygenating a patient who is in the saturation? Dennis can go through and then tell us more on that. Thank you.
Thank you very much, Dr. Francois, for the nice introduction. So after reviewing how COVID patients are isolated, triaged, we are going to see the main therapy they receive when they are in the treatment centers, which is oxygen therapy. Next slide, please. So generally, oxygen is offered to patients who are having difficulties in breathing, like respiratory distress, or they are hypoxamic. When you see the readings on the pulse oximeter, or you are interpreting the arterial blood gases. So when the patient is hypoxic, you need to address that so that you avoid potential complications from it. So we have seen in the previous sessions different tools we can use to give oxygen to patients. In this session, we will see when and how to provide oxygen and when you can escalate from one tool to another. So we have seen nasal cannulas, facial masks, masks with reservoir. We have seen Venturi mask, we have seen the high flow nasal cannula, we have seen the Cpap, BiPAP in non-invasive positive pressure ventilation. So in the next slides, we shall see when one can be used and when to move from one step to another. So, generally, you start titrating the oxygen starting with the nasal prongs, where you can give from 1 to 5 liters per minute, and they provide FiO2 ranging between 24 to 35%. And the nasal cannula, the same, nasal cannula is the same as the nasal prongs, don't get mistaken. So the facial mask, which is simple one without a receiver, you can give from 6 to 10 liters per minute, and you provide 40 to 60% of FiO2. Then the Venturi mask, which can go up to 15 liters, and you can also use non-rebreather facial mask, which can provide between 60 to 90% of FiO2. Next slide. So whenever a patient is failing from a nasal prong or nasal cannula, you can move to a simple mask. If they fail, you move to a mask with a receiver. Then when they fail, you move to high flow nasal cannula or the Cpap or BiPAP. So at each step, you have to look your patient and see how comfortable they are, and rather than treating just at the number. A patient may have 87%, yet they are able to do anything they can at ease. So don't just rush if a patient is having like 50% on simple facial mask and dash to intubating that patient. You have to consider the general status of your patient. So generally in the general population, we provide oxygen support when the patient is desaturating below 92%. But in some circumstances, like for patients with COPD, the chronic obstructive pulmonary diseases, and other similar conditions, you need to provide oxygen when they are desaturating less than 88%. And you titrate your goals to achieve between 88 and 92%. So in the acute mainly in the chronic conditions of hypoxemia or hypoxia is where you target between 88 and 92. but in the acute settings, you target above when you give oxygen when the saturation is below 92%. Next slide, please. So here is how you can escalate your oxygen therapy for your patients. As we said, if someone is failing to achieve your goals using the nasal cannula, which can provide up to 6 liters as we have seen, you move to simple mask or Venturi mask. And if you are still not yet achieving your goals, let's say you are dealing with a patient who is having COPD who are got COVID-19, your goals is to move above 88%. If this is not achievable by Venturi mask, you move to a mask with non-brief reservoir. And if that one can't achieve again your goals, you go to high flow nasal cannula to see if you can support well your patient. Again, if the high flow nasal cannula is not able to support your patient and achieve your goals for oxygen therapy, you go to non-invasive positive pressure ventilation, where you have two choices, the Cpap and the BiPAP. So the Cpap mainly is to give a continuous positive pressure to try to open the alveoli, as the main cause of hypoxia or hypoxemia in the setting of COVID-19 is the atelectasis. You have to open the alveoli by providing a positive airway pressure. Why for the BiPAP, it's not a continuous positive pressure. It's you set two pressures, one for inhalation and the other for exhalation. That's why it's called bilevel or BiPAP. But generally, the setup or the function, the design are the same. So when you can't achieve your goals using a Cpap or BiPAP, you move or you have to rely on intubation to try to see if you can save your patient. Next slide, please. This busy table is almost addressing the previous one. It's generally if you are having a patient who is at risk of hypercapnic respiratory failure, where you have CO2 retention and the partial pressure of CO2 in your blood is greater than 50 millimeters of mercury, as we have seen in the previous session, where in the types of respiratory failure, this one is a type 2 respiratory failure. So if the answer for that question is yes, you have to see if the saturation is less than 88. If it is less than 88, start with nasal cannula or nasal prongs with 1 to 4 liters and see if you can achieve your goals. If not, you can try to nebulize if it is a COPD patient who is having wheezing or other obstructive pulmonary disease, or if it is a CNS depression condition which can cause hypercapnic respiratory failure. So if in that case, you also need to do ABG if you are in a setting where you can afford it. And if your pH is less than 7.35, you have to consider non-invasive ventilation, the Cpap or BiPAP. If the SpO2 is above 88%, you don't need oxygen support. You only have to monitor your patient and try to do ABG to see who is a patient at risk or who is requiring very close monitoring. So when they deteriorate, you do the same as previous. You consider non-invasive ventilation and try to contact ICU or HDU units to try to help your patient. If your patient is not at risk of hypercapnic respiratory failure and their respiratory, their SpO2 is above 92, you don't need to do anything. If they are desaturating below 85%, you start oxygen therapy using nasal cannula, and if you are not reaching your goals, you use a facial mask. If you fail, you try to use high flow nasal cannula, and then as you are not reaching your goals, you can try to contact ICU, HDU to provide positive airway pressure to support your patient. Next slide, please. Yes, again, this table is to show you how you can escalate the oxygen therapy from raw flow nasal cannula to intubating your patient, or even providing exchange corporal membrane oxygenation if you are in a setting where you can achieve it. So generally, the key message in the last two tables is to explore the possibilities that are in your settings and try to escalate the oxygen therapy means if you are not yet achieving the goals for the patient you are supporting with oxygen therapy. Next slide, please. Yes. So when to involve a senior physician or ICU team when you are providing oxygen. Generally, in a patient whom you are requiring more than 6 liters per minute with a simple facial mask to maintain optimal or adequate SpO2 saturation, you need to contact or alarm the ICU team or HDU team. Or if your patient whom you are supporting is requiring more than 8 liters via a face mask to maintain adequate SpO2, you have to alert the ICU team that you have someone who is requiring ICU admission to be supported. So providing critical care outside ICU is not the best because your patient is in danger when the oxygen requirement is, they may need intubation anytime. So ICU or HDU are your resource to try to optimize the care for your patient who is requiring high oxygen requirements. Next slide. So here is the table showing you different target goals for different patients whom we are treating with oxygen therapy. In COPD and other chronic lung diseases, you provide oxygen when they are desaturating less than 88%, and your target is between 88 and 92. In pregnant women where the oxygen demand and the respiratory reserve is diminished, you aim higher oxygen saturation. So your threshold to provide oxygen should be, it's very minimal. So when their saturation is less than 94%, you need to give oxygen so that you support them. Their demand is very high. So that's why it's generally requiring higher oxygen support than the rest of the population. So in children or infants, it's a bit lower. compared to pregnant women or general population who are acutely decompensate, where you target above 92%. In children, you aim to give oxygen when they are desaturating less than 90%.
Yeah, there is the internet connection from Venice. He's explaining the adequate SPO2 target or goal in a special population. So here means that when you are delivering oxygen, you have to think twice. In which case are you providing?
That, when you provide.
Yeah, you have to know in which case you are giving oxygen and how much oxygen you are going to give. You see, in 70 case, you have in short case, you have to consider oxygen in SPO2 more than 94. By the way, here to remind also in trauma patients, you have also to give oxygen when they come to you, if they are less than 94. So this needs more oxygen because the brain is working in intensive situation. Next, please. As we are talking about escalation of oxygen therapy, we talk about non-invasive devices or non-invasive oxygen therapy. Here there are different places. We are having non-invasive oxygen therapy and those things which you are using from nasal cannula to high flow nasal cannula, but there is no any invasive procedure to the patient. Here we are also having non-invasive positive pressure ventilation. Now here we are having positive pressure, meaning naturally or physiologically we don't need to have this positive pressure. We are negative pressure ventilation with non-invasive. There is no additional positive pressure. So now we are going to talk about when you failed to use a non-invasive oxygen delivery with pressure, positive pressure ventilation. For instance, we are talking about a Cpap and BiPAP. So the key is that this mode provides the positive pressure through the respiratory cycles. Commonly is a tight face mask you see around here. This face, when you put it on the patient is on mechanical ventilation. Is on the mechanical ventilation, but without intubation. Is non-invasive. So you have to tightly fix this mask and sometimes discomfort, and then you can set the PIP you want, and this PIP may make the patient an comfort, but will also help as the presenter was saying, open up the alveoli which are already atelectatic when you are failing to oxygenate your patient. Cpap or BiPAP are useful for patients who are obese. As you know, obese patients are experiencing what you are calling obstructive sleep apnea. In that case, also you can use them. So COPD patient is beneficial also. And also you have to use it for patients who are unable to tolerate the prone position, which we will talk later in the presentation. The combination of CPAP and the BiPAP with the prone position is better and will help you to do recruitment strategies. And for this non-intubated patient, why we're talking about recruitment strategies is that way the maneuvers you are using to open up the alternatively your alveoli so that the alveoli are kept open. And when you are having this proning position, as you see, the proning position will be explained later, but it's a kind of making free your lung. When you are in a spine position, there is a pressure or weight of the heart to the lungs, and the lungs doesn't have place to expand. But when you have proning position, you are freeing your lung to expand on the back. And when you put a CPAP or a BiPAP, there is the place to expand, the expansion, and then the alveoli will be more and more opened. Next, please. So Cpap and the BiPAP, we talk about Cpap or BiPAP as considering the mean airway pressures, which is what causes recruitment, as I was explaining about expansion and alveolar opening up of the lung. And then from that, the air has where to do gas exchange. For the Cpap, the mean pressure airway is a PEEP. I talked about it. And for the BiPAP, we must have expiratory pressure. We have inspiratory and expiratory pressure. We have two pressures, which we have to set at a different level. And Cpap, as we said, doesn't increase the patient tidal volume, whereas the BiPAP, we will be having those two pressures may also having a matter of causing barotrauma, so that there is a setting you have to be on. Here we are using 16 centimeter over 12 centimeter. There is centimeter of water because they are using a pressure. One is for respiratory, the other is for expiratory when you are having two level as BiPAP. So the Cpap is better as to lung protective ventilation, and they will not cause more harm of having like pneumothorax of other things from the ventilation. From here, you have to know we are escalating oxygen therapy from the nasal cannula to this non-invasive pressure ventilation. And if you fail it, so then you go to intubation. You intubate the patient, and as your aim of having SpO2 targets be met. Next, please. In COVID cases, actually, the non-invasive pressure ventilation is not recommended. It's not recommended because it can spread this aerosolizing thing, and you can also increase the spreading of COVID. It's not recommended, but it doesn't mean it's not useful. It's useful in such case. So when you use it, you must wear your full PPEs. You must also have a viral filter where you must connect them with the mask we saw there. And also you need to have adequate seal with non-invasive mask, as I explained, so that you prevent the leak of the volume you are setting, the pressure you are sending, and the patient is not well ventilated as you need. You have to keep FiO2 at 100, but you have also titrate the FiO2 as the oxygen also is toxic. The PEEP has to be titrated to get your targeted SpO2 according to the situation you are facing, either shock, COPD, or others as we explained above. So the blood gas, you can do them if you have facilities, and you make sure that your non-invasive pressure ventilation is in a closed system. Here, when we say closed system, we mean that you have a patient with the mask on the mouth with a good seal, and the system from the circuit system to the machine to the oxygen source, so that your patient is on mechanical ventilation without intubation, either on the trachea or nasal. Next. Yeah, to this, when I want to talk about respiratory failure by Dr. Joseph, but before we talk to the respiratory failure, we want to the audience some questions from either the first presenter or the second presenter about oxygen therapy. But before they start, the message here is please, we are emphasizing oxygen therapy in our health facilities. When you think, you have to know oxygen is a medication, and you have to know how dose you must give. You have to know which devices you have to use, which flow, and which deliver the FiO2 you need. This is why here we are emphasizing on target SpO2 you want. Otherwise, if you don't understand this, there is a kind of wasting either oxygen, and oxygen is money, or you are not also helping your patient because you are using inappropriate oxygen delivery device to your patient. If from this, then try to see if you are using an adequate oxygen delivery device to the adequate flow with adequate FiO2 to get the target SpO2 you need. To the audience, the floor is up to you. 2 minutes for question about COVID testing or this oxygen therapy in a COVID case situation. Thank you.
Maybe no question.
Even the chat.
I don't see.
Me too.
Okay.
So if no question, let's call Dr. Joseph to take us through the definition of the respiratory failure in general, as the COVID is a primarily respiratory issue. So that Joseph come in and present to us what is respiratory failure and next.
So thank you, everyone. I hope you are hearing me very well. So let's go through a respiratory failure, and you will see the definition, then a clinical presentation. So then we go on possible management and the disposition of a patient. So through a definition, a respiratory failure is called when your blood doesn't have enough oxygen or doesn't have doesn't have too much CO2. It means your oxygen is not enough or your CO2 is high. Sometimes you can have both problem, and this it will be due to inability of the heart and the lung system to maintain an adequate gas exchanges, especially oxygen and CO2. So, of course, as a result, we will see the next slide. We will see the consequence of this condition. Next, please. So, next. So, in this condition, this syndrome of both disorders is characterized by disturbed gas exchange, especially, as I said, oxygen and CO2. The main consequence, your arterial pressure of oxygen will be very low. It means when it's below 60 millimeter of mercury, you know the normal value of this pressure, arterial pressure of oxygen is between 80 and 100 millimeter of mercury. So, of course, when it's between 60 and 80, we call it hypoxemia. But it's becoming below 60, we start to call it a respiratory failure. It's the same for CO2 arterial pressure. You know, the normal range is between 35 to 45. When it's above 50, so we are calling it severe acidosis, which will lead to respiratory failure. So in the next step, on this slide, we will classify those disorders. The first one would be hypoxemia. Next, please. The second one will be hypercapnic. Means the CO2 will be high. So remember our anatomy, where at the level of alveoli, where we are having gas exchange, where oxygen is entering the blood and CO2 is going out from the blood to outside. So as I told, when your CO2 is high, we call it hypercarbic, and when your oxygen will be low, we call it hypoxemia. So, and then this one in the next slide, we will see disorder, especially depending on clinical presentation, even on the timing. Next, please. So, as I thought, type of respiratory failure. The first one to get hypoxemia, it's the level of lungs, where you will get not enough oxygen. The second one for hypercapnic, it will be at the level of the heart, and where your vessels, even your blood, will contain too much CO2. And in classification, let's go to the next slide, where we will see acute failure, subacute, and chronic. Next, please. So I told this classification before. Hypoxamic, as I said, is when your arterial pressure of oxygen is below 60, and the arterial pressure of carbon dioxide is above 50. And then this can be acute, especially it's like an immediate condition. It can take 2 minutes to hours. So then it comes to be a chronic condition, where it's taking more days to even weeks. So this acute or chronic, it may happen either in hypoxemic, loss of oxygen, or in hypercapnic, and high level of CO2 in your blood. Next, please. So, still on the classification, this is really the type of respiratory failure. So the first one, as I said, it's type 1 hypoxemic, where you have a low amount of oxygen in your body. The way you have your arterial pressure or oxygen below 50 millimeters of mercury on room air. It means not on oxygen or not on ventilator machine. So usually this one is seen in patients with acute pulmonary edema of acute lung injuries. So, of course, those disorder will interfere with the lungs' ability to gas exchange between oxygen and the CO2 from your blood. Of course, the management with this acute condition, of course, we will see later. The first one, as we told in the last session, the oxygen is the first one. So, and we need to increase our positive and expiratory pressure to increase the surface at the level of alveoli, as we said before. Of course, in case of pulmonary edema, you will need diuretics to eliminate those fluid causing overload. Of course, as Xavier told in recent slides, the patient can be put in a prone position. We will see later how this position is working. Of course, it's possible to admit a permissive hypercapnia. Of course, we invest sedation, ventilation, or pressure control ventilation. If we have a nitric oxide also can be given, then the last option will be ECMO. So really, I don't feel we don't have ECMO in our settings. Maybe we'll talk more on ECMO in the later sessions. So let's go on the next slide, and we continue with those classification. So the type 2, as I said before, it was hypercapnic respiratory failure. Really, this is a ventilatory issue where your partial pressure of CO2 is above 50. As I said, it's really in severe acidosis, which would lead to respiratory failure. Usually we see this condition in a patient with an increased work of breath due to airflow obstruction or decreased respiratory system compliance, especially for those patients in asthma or COPD and others, especially what we see it will cause like perfusion and ventilation mismatch. So the third one to be perioperative. I think people are working in theater, you see when the patient is about to be sedated and we get a kind of respiratory failure. This condition is common in our settings especially. And the fourth one, which is the last, really it's due to hemodynamic instability, especially patient with hemorrhagic or hypovolemic shock. So let's go on the next slide, please. And let's go next slide, and we continue with classification of our respiratory failure. As we told before, the first one was hypoxemia, the second one was hypercapnia. You know the definition. So in case of hypoxemia, hypoxamic respiratory failure, so it means there will be low FiO2, especially those people living in high altitude. Of course, the patient will be hypoventilated with ventilation perfusion mismatch. Of course, it will be low. Of course, the shunt, at the level of the shunt, it can be to lead to that. Of course, a diffusion abnormality, and the last one, low mixed venous oxygen called the venous admixture. So in case of hypercapnia, of course, in your body, there'll be an increase of CO2 production by our body, especially fever, sepsis, burn, overfeeding. Of course, there will be a decreased alveolar ventilation, and then your respiratory rate will decrease. Of course, your tidal volume also will decrease, and then your dead space, it will increase. So let's go on the next slide and we continue with the causes. So for the third one, as we thought in perioperative respiratory failure, where your patient may have like atelectasis, your functional residual capacity will decrease. So you know this functional residual capacity is a volume of the remaining air in your lungs after you complete your normal passive exhalation. And you know the normal value is 3 liters at the end of exhalation. So and this one will decrease, especially in perioperative condition. Of course, for those obese people, as Xavier said in the previous slide, where obese people are getting obstructive sleep apnea. So, of course, those patients having upper abdominal incision, which the diaphragm is somehow paralyzed, so that their respiratory rate is low. So, of course, the immediate management, you will start the physiotherapy, especially chest physiotherapy for your patient. If we have a spirometry, it will help you to see how the patient is able to make in and out of his air. Of course, if possible, a patient may be ventilated in upright position, especially you position your bed at 45 degrees. If the patient having ascites, you might drain it to facilitate the expansion of your lungs. So let's go to the next slide to see how the diagnosis, how can you diagnose a patient with respiratory failure. So really most of us in this hospital and Lefebvre Hospital, we are familiar with this condition. So of course we need to make a good, clear and full history. Then you will complete it with your full physical examination Of course, we need some additional tests for diagnosing this respiratory failure. As we told in the last session, pulse oximeter will help you to know if a patient is hypoxic or not. If you have the labs, you do these arterial blood gases. Of course, you look for other causes which can lead to these failures, EKG, chest X-ray, CT scan, and whatever will be available at your facilities. Of course, clinical manifestation, the patient will present you with after the mental status, like cyanotic or raw SpO2 by your pulse oximeter. Of course, this triad, what stress response syndrome, tachycardia, hypertension, and diaphoresis. Those are the features that the patient is really agitated and using extra work or extra work from the accessory muscle use. Of course, the patient will show the really paradoxical respiration, which will be really a good features of diaphragmatic fatigue. Of course, I told ABG also, of course, it will help to diagnose. So let's go on the next slide and see the target of treatment. You know, we go to clinical manifestation, diagnosis. So the rest is to manage our patient. So this management will depend on the duration, as we thought. Is it an acute condition or is it a chronic condition? Of course, we look on severity of disease. Is it severe? Is it moderate? Or is it mild? Of course, at the end, you have to know the cause of that hypoxia. Otherwise, you take the patient partially if you don't know the cause. This is why you need more investigations. The main goal of treatment, of course, as I said before, is to get the oxygen in your lungs. That's one. So the second one, you have to remove the CO2 from your body. You know, we got the hypoxamic, respiratory failure, you will give oxygen. Hypercapnic, respiratory failure, you have to remove this oxygen. Then at the end, you have to treat the cause. So let's go on the next slide. The Dr. Xavier said very well the prone position. So really in our settings, we are not familiar with this position. So of course, is the position in which we are putting our patient lying on the abdomen, then we put them on a monitor. This technique is very, very useful for patient in respiratory failure. So, because the benefit, the first one, is to reduce the risk of ventilator-induced lung injury. So now when the patient is on a vent machine, this is the first and the more complication they might have. I call it ventilation-induced lung injury. So another one, remember our anatomy. When you are on the supine position, it means when you're lying on your back. You know, the heart is like applying a pressure on your lungs. So, but in this condition, when you are on the prone position, there is a less lung compression by the heart. Of course, the result will get more efficient gas exchange because your lungs are free. Of course, another one, the real improvement of the heart function, also because the heart will be like on near the bed. Also, the heart function will increase and the oxygen delivery to the body will be better. So it means this position will improve oxygen delivery and CO2 out. So let's see the second one to see really the condition of ICU admission. Next slide, please. So our patient, after getting clear history, full examination, diagnosing the patient, then targeting our goals, and really we need those condition or those criteria for ICU admission. So those validated criteria are classified into two types. The first one is major criteria, and the other one are minor criteria. So the major criteria, the first one will be a septic shock. It will be the patient who need the vasopressors. Another one will be a patient with respiratory failure. Those patients will require mechanical ventilation. And in the case of minor, you can see respiratory rate, duration, arterial pressure of oxygen on FiO2 pressure, which is below 250. Of course, the patient with medullary infiltrate on your X-ray, like confusion, anatomical status, uremia, leukopenia or hypothermia, of course, hypotension. So those criteria are validated, and you will see what patient, which condition is having, and which criteria is he meeting. Then you can say, oh, let's send the patient in ICU. So let's see the next slide, please. So those are indication of intubation. Of course, the first one is if a patient is deteriorating, really we need immediate intubation. Of course, endotracheal intubation, the first one, and then you can include the sequence if it's failing, you can need tracheostomy and whatever. Of course, after intubating a patient, you will put on invasive mechanical ventilation. So you can't intubate a patient and put a non-invasive. It's impossible. It means you intubate the patient, then put on invasive ventilation. So then after intubating your patient, you have to decide the way our patient will go. It means the end of your plan. We are called a disposition. So the first one, it's early critical care support. You have to transfer, if you are in a DH, you can transfer to referral hospital. If you are in a referral hospital, you can intubate and then send to ICU. The second one is inappropriate support and to initiate a palliative care if already you confirmed your patient will not recover. Of course, the last one, if you got the point that your patient will not recover, of course, you will initiate the end of life care support. So let's go on the next slide, and we go in our settings. Really, the X-ray, every DH, every referral hospital is having this machine, X-ray. And this one really is helpful in case of COVID-19, So this image is really a real patient in our settings. So there are no identifiers. So we are free to use this image. So of course, the chest X-ray was found to have a limited value as initial diagnosis of COVID-19 with a sensitivity around 69%. This is too big and nice. Of course, on this X-ray, our findings, of course, will be a multifocal and bilateral ground glass opacities on your images. Of course, you found a lung consolidation with peripheral and basal predominance. So this will be like the COVID X-ray. So, and then before closing, let's go back in our school and go on the next slide. Next slide, where we get really a basic skills to interpret a chest X-ray. Next slide, please. Okay, thank you. So really, it's very simple and easy to make a chest X-ray interpretation. So we have a mnemonic called Dr. Pierre. Then you go A, B, C, D, E, F, and whatever. So this Dr. DR will stand for all patient details. Patient details. Then you go with the quality of a good X-ray image. Of course, position. You know, we have anterior, posterior, anterior, lateral, and whatever. Of course, you will see if it was taken inspiration, where we see more than 6 lobes in the anterior lobes. Of course, you see your exposure, especially penetration, where we need to see the cardiac shadow on your film. Of course, this is your rotation. You remember I said you get a symmetry of your clavicle bones. Then you will start for interpretations. So where start, you can see A stand for airway, where we see really if your trachea is in a normal position. Then you will only breathing, where you see your lung filled from top to bottom, to right or to left. Then you see your circulation. You need to see your heart, mediastinum, hilum. Of course, the D stand for the diaphragm. At this one, you need to see both angles. First one is costophrenic angle, so that you can't miss any effusion or free air. Of course, cardiophrenic angle, where you will go see if there's any pericardial effusion. This last E will stand for everything else. Everything else, I will see central line, chest tube in place, LG tube, any fracture, and whatever. So at the end of Dr. Pierre ABCD, of course, you add your impression. It means you will make a final decision or a chest X-ray. Is it normal? Is it abnormal? Then you will decide. So, and then after then you will be able to manage your patient. And then at this level, let's welcome any question related to respiratory failure, if any adjunct, if any support of this presentation, or if there's any experience of what you are doing from our DH or what you are doing our referral hospital. And I hope at this level, you can ask our question or input in any language, English, Kinyarwanda, French, whatever, so that you can get a common understanding. So thank you, team.
Yeah, thank you, Dr. Joseph, for your presentation. There is a question in the chat. Can you please go through it?
Okay. There's a question in the chat from Eric. The question says, you know, we are one in developing countries and most of district hospitals do not have some airway materials for air management for difficult intubation. How health providers should help patients with respiratory failure, epiglottis, and laryngitis? So I think basically he's asking how have most of these sophisticated stuff that we talked about. So if you could please answer the question, sir.
Joseph?
So I think this question is clear. By saying in developing let's see that. Okay, let's go. Okay. The question, okay, is asking how healthcare provider should help a patient with respiratory failure. plus epiglottitis and laryngotracheitis. So I think at this level, first of all, the patient is having respiratory failure. So your target, first of all, here, you will treat a respiratory failure. So those other conditions like epiglottitis and laryngotracheitis, if they are making you not able to do the sequence as we saw, starting by oxygen, remove CO2, doing those steps as we said before. So if I'm not able to intubate the patient because of epiglottitis or laryngotracheitis, so you can go on advanced or surgical airway management. So airway management, it's a course. It's step by step. If the option A is failing, you go on step B. If B is failing, you go on step C. And then until you get on definitive management, which really will be the surgical, where we insert a permanent tracheostomy. So of course, the goal, remember the goal is to give oxygen, to remove the CO2, of course, to treat the cause. So I think I got the answer, unless someone will add something or my answer.
Thank you, Dr. Joseph, for the good answer, and thanks to Derek for the good question. I think to Eric and the other audience, this is the objective of our hub in oxygen therapy and critical care management. So from the question of Eric, to this time, we are encouraging you as a healthcare provider and your leadership where you are working to avail all equipments in managing patients who are hypoxic or who are in respiratory failure, so that you are doing a critical care in low setting where you are. But to now, the question can be when the leadership of our health facilities are not availing all those necessary equipment we may need to help our patients to get oxygen. Reason why I put in the chat that question to the audience. So go back and think about it. So far, we learned many things we can do to the patient before we intubate. Intubation is another thing we'll talk about later. But now let us, with our available resources, try to help our respiratory failure, hypoxic patient where we are. This means to go to talk with your leadership, tell them what is necessary. Remember, yesterday I shared with you the, like in between intubation and the non-intubation device to give a PEEP of a patient who is on nasocannula, the device I shared with you. So try to have all necessary equipment you need, and as we run here, and then I think before of thinking intubation and mechanical ventilation, do your best as critical in your setting, and then if you don't have them, transfer where they are. Today's session is transfer to the higher level of care, but have the minimum to help your patient you can do. And the chat, Dr. Ponet shared that, Eric, there is a way to refer those patients to center with material for intubation and airway management. Yeah, thank you, Dr. Ponet. But before this, let's encourage the people to have the minimum in their settings, because you can refer someone. Let me give an example. Yesterday, I was in a general hospital somewhere, and they sent us a patient who was saturating at 30% on facial mask, please, from 3 hours away of that hospital, so that have the minimum to help our patients. And if you want to transfer, meeting the criteria, transfer someone who you already managed to your low setting, to your referring level. So that's it. We are running over time. Please allow me to take some key message from this topic, from this discussion. Next slide, please. let us summarize the topic. To the audience and other who may have this presentation, you must have hospital admission criteria where you are, and you know when to admit and you know when to send back home. You have to understand how, while managing COVID-19 patients, how in which category of severity they are, either asymptomatic, mild, moderate, severe, or in post-COVID. And then we are encouraging you to have equipped isolation room in your hospitals and have all equipment around it, and you know how you aspirate or de-escalate oxygen therapy as you go up, and then you are getting your target. You may also win slowly and progressively to down until Rumea. Know when to do escalation of care, indication of transfer, and try to do some critical action where you are, and you know how to interpret the chest X-ray, and try to encourage your patients in a working positioning and see if they can improve oxygenation. So try to identify at any time the respiratory failure of your patients. Our practice changes action. Our practice changes action are just have around you all necessary equipment, have isolation room in your setting, and try to know when to or senior or critical care providers for consultants. And then with this, I think our patient may be managed and appropriately in our health facility where we are during our arrangement to transfer to the higher care. And therapy is a key in this time of COVID. So please have all necessary equipment. And if you don't have them, try to ask your administration for supply. Thank you for your today's attendance. We have some communique. I want to recall or to remind the audience that the criteria for CPD credit and certificate is to have attending 9 out of 12 session, meaning 75%. We are recording all your attendance. And with this attendance, you will get your certificate and the CPD credit. Our next session is on 1st December 2021. We will be having like round table questions. We will be working in breakout sessions so that we are having like questions to answer as audience. So go back and revise our learning resource center, try to understand what is in. We will be answering some questions from there. To the partners, if there is any communication from you to the audience, please, India, USA, Ghana, or Nigeria, or I don't remember exactly the country. Okay, please, time is up to you.
All right, thank you, everyone. Thank you so much, Dr. Francois and team. It was a wonderful session. Like you rightly said, attendance is part of, he has decided to make attendance as part of the CPD point. So it would be nice that we consistently attend. Our next session, if you're not in our WhatsApp community, please, the number is on the screen. Kindly join our WhatsApp community. And then the resource can easily be accessed here. Then on the chat, the resource can easily be accessed here. So please feel free to access the resource as you go through. And then, like you rightly said, the next session is our 4th session. It's coming up on December 1st in 2 weeks' time. And the topic will be frequently asked questions. Please kindly send us an email at echo@assistinternational.org. Echo is ECHO, all caps, at assistinternational.org. Thank you so much once more, and thank you so much, Dr. Francois and team. We really enjoyed the session.
And allow me to apologize for today. Today we had the issue of internet disconnection, and also we had to delay our time. Please, we apologize for that on behalf of my team and my co-panelists. The delay in the internet.
No problem. These things are no problem. It's beyond your control, so no problem. Thank you.
Thank you very much.
Mm-hmm.